Welcome viewers. So today's session is about decoding complex PCI. It's a case of tortuous calcified right chondriatal lesion where we did block modification with rotablation through guide extension. I'll take you through certain nuances of how to use rotablation through guide extension. This patient is 78-year-old, NST and QMI, failed PCI before. And you can see clearly it's a very tortuous right coronary artery, and it's a near total occlusion in the distal RCA. And you can even witness severe calcium present, almost Tom track calcium seen in mid and distal RCA. And if you look at RIO view of this right coronary artery, you can see there are almost 3 loops in this artery. Okay, see there are 3 loops in this artery. So, and this is the reason, why in such patients, when you do rotablation, see the possibility of rotabar going across this lobe with a furrowing effect is very high. So you might see some perforation at the end of rotablation, at this part. So that's the whole problem. But majority of the calcium is sitting in the distal RCA. So if we do block modification, it's very important to reach this area for block modification. And to reach this area with a ablator and avoid this area, the only way is by putting a guide extension catheter, so which avoids, ablation in this area and furrowing effect. So this is what, happens with guide extension. When you put guide extension beyond this first lobe, so you are trying to centralize, your burr position, and that centrifugal, burring doesn't happen. So it's predominantly, kind of central burring, which happens. So your burr will go through the vessel like this without much furrowing effect. So, and for this, one more important thing is always start with a small burr in such situations to prevent, vessel perforation or deep furrowing by rotablation burr. So this is what we have to understand before you take burrs through guide extension catheter. You can see the compliance chart are, the 7 French. See, out of all guide extension catheters, GuideZilla is the best guide extension catheter because that provides the largest lumen among the guide extension catheters. And you can see through 7 French guide extension, you can take 1.5 bar. If you want to take 1.75, you need 8 French, GuideZilla. In this case, we used 7 French because our plan was just to create a space for IVL balloon subsequently. So it's a kind of rotatripsy, not predominant, not just rotablation. So, and this is how we approached. You can see the case. So we started with AL guide and with guide extension, and then through that, cord side row and wire. So this is how we started. So this is very important to understand. So we have to go preemptively with all the support maneuvering to send wire as well. So you can see we crossed this loop, but this is where the lesion was very calcified and near 99% occlusion with a microchannel filling the distal vessel. So workhorse wire got stuck here. This was cyan blue wire, which got stuck there. And subsequently, we de-escalated, we took a wire to filter XTR. You can see it's a microchannel wire. So with microchannel wire, we could cross the lesion, I'll just take further. This is a filter XTR wire. So with this wire, you can see how I'm handling. So only rotate this wire. Don't try to push. So if you try to push or direct this wire, you end up in a dissecting vessel and, closing the microchannel so that your further attempts becomes more and more, difficult. So just keep rotating. So wire will choose its own path. You need not, struggle there. So you can see I'm just rotating. So I'm not directing. You can look at my fingers. So it will cross the lesion without much difficulty. So I can just push you through. Yeah, I can see. Yeah. So we crossed. But what we have to remember here is even for wire crossing, in such lesions, you need immense support. So the support we garnered, by telescoping catheters through other catheters like guide extension through guide and micro-catheter cord through guide extension. So this is the kind of support we have to create even for wire crossing. Wire crossing also needs immense support in such cases. So we could cross with filter XTR. Now it is in PDA, you can see. And we tried sending Corsair down, but Corsair got stuck here. So it was not progressing beyond this point. So that's when we realized we have to create a space with smallest balloon available. So yeah, we can see here. So we started dilating the lesion. So we took a 1 mm balloon, but 1 mm balloon got stuck here. So it was not going beyond this point. So I did a granuloplasty. So we dilated balloon up to more than 20 atmosphere till it gets ruptured. And once the balloon got ruptured, so we removed the balloon and then we took, further balloons, next balloon down, and that next balloon, in fact, went much easily. That is a 1.5 balloon. So 1.5 balloon got down. You can see now the balloon is in the tightest lesion. So we dilated entire lesion with 1.5 balloon. And subsequently, we dilated even with a 2 balloon just to create a space. And post that, so what we did is, you can see here, so we again tried sending Corsair down. So you can see this is a Corsair catheter. After creating space, so still we had a lot of difficulty going across this bend, but we could, since Corsair is torqueable catheter, so by torquing you can garner further support and push the catheter. So that's the reason this is the ideal catheter in this case. So not any other micro-catheter. So you can see we torqued. You can look at my fingers, how I'm torquing and pushing this catheter. So, and at some point, it gives way and got advanced. So you can see it got advanced across the lesion. And once it is across this lesion, so we removed filter XTR, because one of the problem with filter XTR is it won't give support, to your antigrade gear pushability. So it won't support you. So shift to workhorse wire. So we shifted to workhorse wire. This is a workhorse wire again. It's a sand blue. And take that wire deep into PDA. So to get support to Corsair push. So once it gone deep, so then, we advanced Corsair. You can see here, we advanced Corsair deep into PDA. And yeah, you can see, we are advancing Corsair deep into PDA, mainly to exchange to rotawire. So yeah. So once we exchange to rotawire, we can see this is a rotawire, and Corsair is sitting deep in the PDA. So, and once we exchange to rotawire, then I can see here rotawire is into PDA, and then we removed Corsair. See, here, one point to remember is, so once your guide extension catheter is in, this is guide Jilla. So you removing micro-catheter is a bit difficult. So you can't use a trapper balloon here because already your guide is squashed up with guide extension catheter, Corsair catheter. So you can't really send a trapper balloon. So what do you have to do is you have to do all these on wire extensions. So dock extension is key, and controlling, your dock extension is key, while removing Corsair. You can see here. So with the dock extension, we are just removing Corsair, and once Corsair is out, the next step is, rotablation. So this is the rotabar advancement. So in this case, we placed guide extension already into the coronary artery. Since we anticipated a difficulty in sending guide extension into coronary in the beginning, but the shot in the arm here is guide extension went without, any balloon support or distal balloon support. So that's a good thing, to have, because what happens when we are advancing rotabar with a guide extension inside. So you can see in this case. So first thing is, we shouldn't use Dynaglide while we are sending rota when guide extension is already into the coronary, because that can damage your burr surface due to the guide extension shaft located inside the guide. And the second problem which happens here is, which I'll show you. So yeah, so the burr entered. So this is a single operator technique which I'm doing. So controlling wire myself and pushing the burr. So once the burr comes here, so from here when I'm pushing, you can see even guide extension is getting pushed. And when I'm pulling, even guide extension is coming back. So this is something, which happens when you're sending rotabar with guide extension in place in coronary. So the reason is the drive shaft sheath of rota. So that's a Teflon sheath of drive shaft in the rotablation that will hitch onto your guide extension entry, and so that makes your movements difficult. So it's pushing burr beyond your guide extension becomes more and more difficult. And especially when your guide extension is sitting at the angulation. So, and this drive shaft, comes at an angle towards, guide extension entry. So that's why, you will feel a lot of resistance. So what to do in such case is, so you have to just pull your guide extension back. So for that, you have to understand taking guide extension back into coronary should be an easier thing. So you can see here, we pulled the guide burr back, then guide extension back, you can see. And once you pull guide extension back, it automatically takes, drive shaft sheath into the guide extension. Now you can see it is going easily through the guide extension, but you can see guide extension is already back in the guide. So here, the point to be noted is we should be able to reposition guide extension back into coronary easily. So that is something which we have to work before we take rota in. So you create a good space so that your guide extension easily goes back, before even you go with rotabar in this situation. So yeah, now bar is here. So up to this, I have not used Dynaglide, but from here, I just used Dynaglide to reduce tension on the wire or slack on the wire. So, and now we got into coronary. So this is another way of introducing, rotabar through the guide extension to avoid the problem which happened in this case. So just introduce your rotabud through the guide extension outside, and then you introduce rotabud the way you introduce in any other case. You take it up to guide tip, and later you send the guide extension. So it's essentially, we are just piggybacking, guide extension catheter on rotabar up to the guide tip. So this is what we can use. But what we have to make sure in such situations is you create enough space in the coronary till the point where you want to position your guide extension catheter. That is paramount, before resorting to this step. So otherwise, if guide extension doesn't advance after burr is in, then the whole effort becomes useless. So now we started doing, rotablation. So again here, say I already told you, the burr should be the smallest because we want to avoid perforation by furrowing effect. So this is a 1.25 burr. You can see, progressively we are doing ablation. So first I'm doing ablation here because this is a point where I had a lot of resistance for balloons to get in and, cord side to get in. And this is the point where, in fact, we also did granuloplasty. So yeah, you can see progressively I crossed to first resistance. We removed first resistance. Now we are removing the second and the main resistance, which was noticed in this case. So we are burring across the distal lesion. And while coming back, if you want to ablate even at this point, you can ablate while coming back, pull the guide extension down and only ablate this area. So this focused ablation is very, very important. So don't try to cross two proximal loops with guide extension outside the loops. So always neutralize the first loop when you're going through the next loop. So that's very important. So that's what we did here. So yeah, here ablation is complete. And after that, we decided to go ahead with the 2.5 mm balloon dilatation. And then we did IVIS and notified all the calcium score. So still calcium was, around 360 degrees with calcium score of more than 2. So that is when we decided, we go ahead with IVL. So we did even 3 IVL here. You can see the entire area is done with lithotripsy balloon, dilated with lithotripsy balloon. And yeah, after IVL 3, so we also dilated even proximal area with IVL 3. And after that, we went ahead and stented with the 348 stent. You can see this is a 348 stent, and you can see this is the final result. So there is also a lesion in PL, so which we deliberately decided not to intervene, mainly because of the loops present in the vessel and risk of perforation in that vessel. So we left it at this juncture. Yeah, you can just see the first view, and this is the final post-angioplasty view. To conclude, calcified lesions in tortuous coronary artery are very challenging for PCI. Rota through guide extension would maximize support for rota delivery and also minimize furrowing effect in such cases. Guidezilla provides maximum lumen area at all sizes, and per advancement with guide extension coronary, always avoid dynaglide to avoid injury to the bird surface. Guide extension can be piggybacked after rotabur, as I showed, in proximal coronary lesions in suitable cases, or in cases where guide extension can be easily put across the loop after creating space. Drive shaft Teflon sheath interaction with guide extension should be kept in mind while advancing burr in a case where guide extension is already positioned into the coronary. Thank you. You can subscribe to this YouTube channel for more and more such educative techniques. Thank you once again.